Good afternoon and welcome. This podcast is part of the Victorian Bicultural Workers Network, facilitated by CoHealth's Bicultural program. Through these conversations, bicultural workers share their community's experiences of mental health, wellbeing and accessing supports. These stories are shared to help mainstream services better understand the needs, strengths and perspectives of refugee and migrant communities, and to reflect on how they can work more effectively and safely alongside them. Before we begin, we acknowledge the traditional custodians of the land on which this podcast is recorded, the lands of the Wurundjeri, Woonwurrung and Boonwurrung peoples of the Kulin Nation. We pay our respect to elders past and present, and we acknowledge that this work takes place on stolen, unceded land. We recognise the enduring leadership, strength and wisdom of First Nations people in navigating, surviving and challenging colonial systems and in bridging divides to support the wellbeing of their communities. My name is Jasmine and I'm the Bicultural Program Lead at CoHealth. Joining me on the podcast today is Nesrudin Mohamed Salah. He's a colleague of mine in the Refugee Health team at CoHealth, and I'm really excited to have you here, Nesrudin. How are you?
I'm good. Thank you so much for having me, Jazz.
Thanks for joining us. Would you like to tell us a bit about yourself and your work and your community?
Yeah. So a bit about me. I come from Ethiopian background, from the Harari background. I've been in Australia since 2011. That's when we migrated to Australia. I am a registered nurse. I've started off working in emergency and then slowly have transitioned into the refugee health nurses space. So I've been doing that for the last 2 years here at CoHealth, and I'm based at the Kensington Clinic. And so most of my work pretty much revolves around working with newly arrived communities as well as people seeking asylum with multiple different sort of backgrounds as well. Over the last few years, I've been involved within the Victorian Refugee Health Network, which has exposed me to a bit of mix of like clinical work as well as like systems level advocacy, and all intertwined into trying to improve how services respond to culturally diverse communities.
What do you think are some of the greatest strengths of your community?
I think one of our biggest strengths would be the combination of like resilience and a lot of spiritual grounding as well. We're quite connected and everyone knows everyone, and that is our strength because the reliance on community and family like is pronounced within our cultural background.
It's been so interesting doing these interviews, how that theme of community connectedness has been the strongest and clearest message that bicultural workers have shared about the strength and resilience of their communities. From your lived experience, how would you explain your community's understanding of mental health and wellbeing, and what kind of words or concepts exist in your language to describe it?
Yeah, the understanding of what mental health is quite different to the Western sort of model understanding of what mental health is within the Harari community, I would say. They do have an understanding of what it is and what it entails, but it's a spectrum where there isn't a lot of words to describe like the different mental health diagnoses that exist. And so we just have one or two words to describe. And oftentimes these words, they have a stigmatization connected to them as well. If you do a direct translation to English, the literal translation for it is like he's crazy. But people do have other ways of describing the mental health illnesses. So like, for example, they would say his heart is hurting. Or if people are like depressed, they will say, oh, like I feel heavy or my chest is tight. That's pretty common as well. Because yeah, the direct words that we have for it, like oftentimes have like very negative connotation to it as well. So people oftentimes will just try to go around it. And when they do go around it, they describe the symptoms instead of the actual diagnosis of what it is.
So fascinating. Last episode, I was talking with Shadow, who is from the Karen community from Burma, which is obviously the opposite side of the world to
Yeah.
Ethiopia and a very different culture. And she shared a very similar thing, that in her language, people talk about the heart as being the center of how they describe mental health, and that to the point where more unpacking is required to understand whether or not you're talking about like a cardiologist or a psychologist or
Yeah.
because it all comes back to the physical descriptor of the heart, which I just found fascinating, and fascinating that it exists across cultures as well.
That's interesting. Yeah. In the Western sort of model, like you tend to hear of there's so much to mental health and there's so many other diagnoses, like so many diagnoses that do exist. But
Mm.
trying to do that direct translation into, say, like the Harari language, it's very difficult. And we used to see that quite a lot, especially in the emergency department, not just within the Harari language, but I think Ethiopian language in general.
In your clinical work as a nurse, how do you approach conversations around a person's mental health and well-being when you're in a clinical setting? Is there a way that you ask questions to ascertain whether or not a person might need support, or how do you approach it knowing that language is limited?
Oftentimes, for me, I would say I revert back into going to these symptoms that they describe. And a lot of times they would say, oh, like maybe I don't have peace, or the last like a couple of days, my chest has been like heavy. And I look at the key symptoms that they describe, and then I
Mm.
just try to like explore more of what do they mean by that. And so oftentimes like that really opens up into, oh, okay, like this could be connected to mental health symptom. And yeah, so going by like the keywords that they would say.
And do you think that's common practice, Nesrudin, or do you think it's your lived experience of being a person from Ethiopia who understands how language works for a lot of the refugee clients that you might see? You bring a lived experience lens that maybe other practitioners aren't adapting their language in the same ways, or do you think it's quite commonly known across the profession?
Definitely, I would say it's due to the fact that I do have the lived experience. I think
Mm.
100% I would say that. Just because we do see some clients, we might see them and they might be, for example, describing these symptoms as, oh, my chest feels heavy or my chest feels tight. And oftentimes, I think when we were learning in the university, when somebody speaks about their chest feeling tight, the first thing that you go to is cardiovascular.
Yeah.
And it has happened. People do end up going into emergency departments, or they would have all of this investigations done for cardiovascular issues, which ends up coming back as negative. And then they are told, you know what, you're fine, your chest is fine. But they go home still thinking that, oh, I don't feel good. And so it creates that challenge for the patients themselves as well.
And to access the support that they need and to be understood from their
Exactly.
frame of reference. It's so interesting. You've just made me think about, for many years before I started working at CoHealth, I worked as a sign language interpreter. In order to be a sign language interpreter, you cannot be a deaf person. So you're interpreting with your lived experience, being as a person who hears. And so often, if we're working with a community member who is profoundly deaf and has grown up with a deaf family and they're entirely immersed within the deaf culture, sometimes the way that they express their lived experience is hard for a hearing person to understand, even with all the training that we have as interpreters. So sometimes we will bring in what we call the deaf interpreter. So we have the deaf client who talks about their needs, the deaf interpreter who will understand it from a cultural lens and then produce it in a sign language and unpack the meaning behind what the person is trying to express in a language that's digestible for the interpreter. So the interpreter can then talk to the health practitioner. And it's such an interesting dynamic because it's essentially what you're talking about, where you bring a lived experience to your clinical role, which enables you to understand the frame of reference that your client is talking to you from, that other practitioners may not be able to understand. So you just made me think of that. It's so fascinating.
That's really interesting that there's a lot of interconnectedness there.
Yeah. I want to ask about how your community or refugee communities that you work with seek help or support when they are struggling with their mental health. Like, for example, who would they speak to first? Are there any traditional or cultural ways that community members might deal with their mental health?
Yeah. I think within our community, I would say seeking help usually starts within the community, to be honest. And often the first people that family members would go to would be like other family members that have been maybe in Australia for a lot longer. And also they do reach out to people that are respected within the community as well. There's this thing that exists within the Harari culture. It's called Afocha, and a lot of Ethiopian cultures have it. And Afocha is basically where communities getting together to do networking, where people will meet after, because everyone gets so busy within their lives, and they might have a weekend where they'll just get together and just catch up. And there's the women's Afocha group where they would meet maybe once a month. And so if there's any particular issues that people might have, oftentimes these groups are where the discussions will start off, and then that leads to other avenues from there.
I was talking to a South Sudanese woman the other day as well who talked about, I can't remember the word that she used, where men will come together in the evenings after work, often in the street, in the community, to talk politics. And they're not necessarily talking politics, but it's that social connection, the carved out time and space for people to connect and speak to each other.
Yeah.
What about faith? How does faith and mental health intersect in the Harari community?
Definitely faith is central to how it shapes people's understanding of mental health, as well as the general understanding of what hardships is. And within the Harari community, majority of it is Muslim faith based. And so there are concepts within the Islamic faith that exist, such as having patience, or we call it sabr, or tawakkul, which means trust in God. And these are like really deeply embedded both culturally and religiously. And so it is like the intertwining of the faith aspect as well as the cultural aspect of it as well.
Mm. And what about migration, resettlement, displacement? Do you think these have shaped the way that your community experiences stress or mental health?
Yeah, absolutely. It definitely has shaped our understanding of what mental health is, because with migration, there's a lot of layers of stress that comes with it as well. So a lot of times people will have a level of past trauma that has been associated with their level of migration as well. Family separation, that's a really big one. Loss of identity, where second generation, maybe Hadareens, might not really connect with their first generation or parents' generation. And also just there's a lot of, not just I would say the Harari community, but within the refugee cohort that I tend to work with, there's a level of guilt that they do have. And that comes from, oh, I've made it out and I'm like here, but the rest of my family is stuck and they can't come and join me here. So that really places a heavy burden on and on a lot of cohort that we tend to work with. And it's not something that people always like express this openly. And there is this silent endurance that they carry with them. And that is as a result of the migration and displacement.
Yeah, I was recently working with a young man from the Horn of Africa who was struggling in his own journey of resettlement financially and emotionally and dealing with all the things that you just mentioned. And one of the things that came up quite a lot in our conversations was that just feeling like everyone who back home had supported him in his journey to come to Australia were now angry at him because they thought that once landing in Australia, it's the promised land. You're going to have wealth and riches and endless opportunities. And often that's not the case for a lot of refugee and migrant communities when they do resettle in Australia. And that guilt is heightened by not being able to support the families back home in the way that they might be expecting based on your newfound privilege or so-called privilege. I hear that a lot with people in my work too. You mentioned as well, you touched on, and I wonder if you'd like to expand a little bit about the intergenerational challenges that people face and how culture shifts for the younger generations. Do you want to talk a little bit about that?
Yeah. There's a big shift that happens like within the newer generation or the second generation. Australians either being born here or coming to Australia at a really young age where they really quickly adapt into the Australian culture or norms, and which will take sometimes for their parents to get to that level. Sometimes it can create a bit of a gap between the parents and their kids. And so sometimes they have this understanding of, oh, they just, it's just a phase kind of thing. But I could see it with some of my friends as well, like where they really struggle with even identity because they like, I'm not really fully like Ethiopian, for example, or really, I don't feel like fully like Australian and like, where do I sit? You do get that a lot, but yeah, like it's a work in progress.
What would an ideal mental health service look like, where people would feel safe and welcome and understood from a cultural lens?
I think, yeah, like the Western approach, like it's a very, very beneficial model of working. But I think a lot of the therapy that we have definitely is individually focused. But when we're talking about, let's say, like the Ethiopian community, oftentimes like it's much more than the individual. The individual might be in the center of the attention, but they do come in with like other families involved. It could be their partner or their children. It could be the people that accepted them when they first came into Australia, for example. And I feel like sometimes services do ignore that or would not put that at the front as well. And so it all pretty much comes down to clinicians being culturally aware and trying to openly incorporate these kind of elements as well within their therapies, which can have better outcomes, especially for these communities.
Mm.
And also ensuring that faith is at the center of how they cope as well, ensuring that aspect of it as well is included. And especially, I would say, with a lot of cultural groups that come from non-English speaking background, oftentimes trust takes time and it's something that can't be rushed as well. And it's important to really understand that and be patient. It's also really important to pay attention to that oftentimes people do have multiple competing responsibilities. People just recently arrived into Australia. They might be looking for work. They've got to get their bank in order. They might need to go to Centrelink. And there's all of these things that they are in the process of building. And so it's important to really pay attention to those things as well.
Do you mean in terms of timing, like when getting access to supports for mental health might be a priority for a community member, or just supporting through flexibility as they navigate all of those challenges during settlement?
I think just supporting them. If their mental health needs to be addressed ASAP, then that's something to do. But it is a process that can take some time as well.
Mm.
And
Mm.
it often takes time because of all of these other competing factors that they have.
I want to ask one more question and then I'll give you the opportunity to add anything that maybe you feel like you haven't had a chance to speak on yet. But I just wanted to ask from your perspective, what role do you think bicultural workers can play in supporting communities' mental health and access to support services?
To be honest with you, the first time I heard of the bicultural workers was when I started my refugee health nurses role a couple of years ago. And it's honestly, it's such a key role because oftentimes bicultural workers understand both the system and the community as well. And the fact that they're like actually embedded within the community and oftentimes are like familiar faces where people actually know them within the community as well. And so it's so much easier for people within the community to approach them because they've already built that trust. And when I was mentioning about the different groups of the Afocha or the women's group within the Harari community, anytime maybe a bicultural worker can come to these sort of events and be like, okay, there's X, Y, and Z have been happening. And it's like people that have been looking for assistance or guidance into where to go is, oh, actually, I could just go to this person. And they've already connected at a systems level. So it's really crucial because it actually prevents people falling through the cracks as well, which
Mm.
is so common. Yeah.
It's interesting, I think, across the mental health sector and the health sector more broadly, bicultural workers are not well understood, and there's a mix in thinking that a bicultural worker is somebody who's employed in like a designated lived experience bicultural worker role, like in our teams, or someone like yourself might be referred to as a bicultural worker as well, a person of colour with a lived experience working in a clinical role who brings that dual kind of experience to supporting communities. And I think both is really essential, yeah, like having designated roles who can go out and, like you said, do that community engagement work, build the trust, build the relationships, and bring people into the services, but then also ensuring that the services have a diverse workforce that are able to continue that culturally safe care once people do enter into the system.
Absolutely. Yeah, I 100% agree to that.
Do you have anything that you feel like you really wanted to share on the podcast or that we perhaps haven't had an opportunity to talk about that you'd like to add?
Not really. I was just going to say maybe it's important to note that for a lot of Ethiopian or Harari Muslim communities, like when it comes to mental health healing, it's just not really only limited to clinical, but it's cultural as well as spiritual, and it's also relational as well. And if health clinicians can take that into their practice, that would be an amazing thing. Yeah.
Yeah, awesome. And I think that's a beautiful note to end on. Nesrudin, thank you so much for sharing your incredible expertise with us and having this conversation today. It's been an absolute privilege.
Thank you so much, Jazz. Thank you for having me.